benefits provider. Okay, we got our recording in progress notification. As experts on family planning for workers in unique career fields such as medical residents, Progeny is partnering with CIR for this presentation. However, it's important to note that currently Progeny benefits are available only to CIR residents covered by the Voluntary Hospital's House Staff Benefits Plan. In the course of contract negotiations, your resident colleagues have fought hard to win this benefit, and the fight to extend this benefit to all CIR house staff continues. This presentation will not be outlining the details of fertility benefits coverage for CIR house staff. So for questions about your coverage, and Natasha will add this information in the chat as well, visit our website, cirseiu.org/benefits. Click on your hospital's name. You'll be able to see an outline of your benefits. You can always email the fund office. That's benefits@cirbenefitfunds.org. Or you can call the fund office and we'll drop that phone number in the chat. So any questions about your coverage, we can absolutely follow up on at a later time. I'll hand it back to Natasha.
Thank you. So I would like to introduce Dr. Choi. Dr. Choi is a double board certified reproductive endocrinologist and OBGYN who serves as the chief medical advisor for Progeny. She has written, published, and lectured extensively on infertility, oncofertility, and fertility preservation. Dr. Choi is an active member of the American Society of Reproductive Medicine, the American College of Obstetricians and Gynecologists, and the New York Obstetrical Society. Before joining Progeny, Dr. Choi served as the medical director at CCRM New York for 7 years. Previous to that, she was assistant clinical professor in obstetrics and gynecology at Columbia University Medical Center and served as the director of oncofertility and the co-director of the fertility preservation program. Dr. Choi earned her medical degree and completed her residency in obstetrics and gynecology at Columbia University. She completed her specialty training in reproductive endocrinology and infertility at Weill Cornell Medical College in New York. Welcome, Dr. Choi. We are so excited to have you today.
Thanks so much, Natasha. Appreciate it. And thank you all for taking time out of your super busy day. Maybe you just took a midday break. So again, very happy to talk to you about how fertility affects physicians in particular. And what options lie ahead for you. I don't want to raise any alarms. I don't want this to be alarmist. This is purely educational, some of which you probably already know. I am always happy and open to answer questions. I may not have answers for everything, but I think to try to help with the flow, Clara's going to oversee the question collection. And unless there's something that's really pertinent to the slide that I'm talking at hand, we're going to keep them to the end so we can have a very robust Q&A afterwards. So if we could just go to the next slide, please. Right, so today what we're going to do is talk about, because I think all too often, especially as physicians, especially as training physicians, we're sacrificing and we're trying our best to take care of the patients we're serving, and sacrificing like our needs and looking out for our own like reproductive health and potential. So we're going to talk about the prevalence of infertility, how it affects physicians potentially differently and maybe at a higher prevalence rate versus the general population. How to support your reproductive health now and into the future, and then talk about additional resources that are at hand. Let's just go to the next slide. So infertility in general, which is the inability for a person born with ovaries to conceive on their own without any medical assistance for 12 months or longer. Although quite honestly, we'll talk about other factors for those individuals who are 35 and above. Oftentimes physicians will say, you should start thinking about getting help if you've gone for about 6 months or longer of ovulatory cycles and no conception occurring. And the prevalence of infertility overall worldwide is rising. So the WHO released stats about a year and a half ago, citing that about 1 in 6 individuals worldwide is affected by infertility. Interestingly enough, or maybe not so surprisingly for those of you who are actually experiencing this yourself, 1 in 4 female physicians actually experiences infertility. And that could be the inability to conceive with ease without any medical intervention after a certain amount of time of trying. And it's incredibly frustrating and upsetting to anyone, but particularly, I think, for providers who are taking care of patients. You feel like you need to have all the answers, and why isn't your body kind of complying with, your knowledge base? And that also encompasses those individuals who are trying to build their family and yet suffering miscarriage after miscarriage, right? So recurrent pregnancy loss is defined as 2 or more miscarriages. And, I just want to keep that in mind as well. Although sometimes treated differently, there are some tools available to address certain types of recurrent miscarriage issues. And yet there was a recent JAMA study that came out in the past couple of years that said only about 8% of training physicians got any education on what the risks are when they seek to delay pregnancy, family building, because they're focused on their education and their career. So again, just want to sort of set the backdrop here. And to be fair, I want to also make sure that the male physicians in the audience, those born with testes, if we can go to the next slide. One of our reproductive urologists in our network, Josh Halpern, is a really prolific, he's a great clinician, and is also a prolific researcher, actually released this recent survey study. And basically he and his colleagues surveyed over 200 male physician residents, I believe, and asked them about their family planning goals and what were the reasons, if they had family planning in mind, that caused them to oftentimes delay. And of the 151 respondents, which is a pretty robust respondent group, considering how busy everyone is and the survey rates here in the country, about 44% had said they delayed family building because of their medical training or career. And then 18% of the respondents, right, in this 40% had said they had seen a physician for fertility evaluation, sperm testing, other questions, hormone testing. And an additional 5% considered but delayed seeing a physician for fertility issues for a variety of different reasons. And about a quarter of surveyed respondents said they'd undergone a sperm test, a semen analysis. And when you look over at this teeny graph, my eyes need reading glasses, but if you want to zoom in, the ones to kind of pay attention to are the ones where you see predominantly high gray, yellow, and green bars, right? So the 3 far right bars, because those are the ones where the respondents said that this had a moderate impact, very much had an impact, or was an extremely strong factor in terms of why they made decisions around timing of family building. And amongst them, stress, no surprise there, not ready, financial issues, flexibility with scheduling because of the burden of all the training and the residency, the fellowship, the education, interfering with family building. And the reason why that's so important is although age does not have as much of a profound impact on fertility for males, for those who are making sperm, if we consider that many of those males are partnered or potentially trying to build a family with a female partner, somebody with ovaries, that person with ovaries, and I'm going to just say, female for the, time moving forward, just to make it a little more efficient in my speech, but also as a placeholder. But also just want to make sure that I'm acknowledging those born with ovaries who don't identify as female, those born with testes who don't identify as males. I don't want you to feel excluded, but I'm just trying to do this for the flow of conversation, right? So if you think that a fair proportion of these males who are training physicians have female partners and understand how age affects female fertility, you can see how much of an impact it might have on this couple who might be deferring trying to build a family because of the training schedule for the male physicians for 1, 2, 3, 5, 10 years. Okay? So let's go to the next slide, please. So the reality of human reproduction, it is unfair, but this is a true biologic fact when we look at female reproduction. Those of us born with ovaries are born with a finite amount and peak number of eggs at birth, 1 to 2 million preformed gametes, oocytes in our ovaries, when I feel like they're the least useful to us, right? And then we don't create fresh new eggs. I know there's a lot of ongoing research, but nothing has really been proven to be that effective. So as we naturally age, we're losing eggs, so quantity, and the eggs that do remain behind, sitting around in the ovaries and the little follicles, their quality starts to degrade. And that means with declining quality, as those eggs continue to age, their ability to create normal, healthy embryos and pregnancies declines. And although that might not be so impactful for, say, someone who's trying to have kids in their late teens or 20s, and by the way, as a little sort of tidbit of information, a newborn infant has about 1 to 2 million eggs in her 2 ovaries. By the time she reaches puberty, menarche is somewhere between the ages of, 10, 11, 16, 17, that egg count is already down to about 300, 500,000, right? And what seems to happen is if you follow along with this green line in this graph, is that as women enter their 30s and mid 30s, the egg supply starts to accelerate in their loss rate, again, through apoptosis and atresia. And people will often say, well, is there a way to protect my egg count? I notice that when I put myself on a hormonal contraceptive item that I stop my periods. Does this mean I'm safeguarding those eggs? The answer is no. Even with hormonal suppression, even with pregnancy, when your periods stop for a certain amount of time, those eggs, just like we slough off skin cells, mucosal cells, are programmed to die off at a steady pace and accelerate. One little lifestyle tidbit for those of you who might engage in smoking, for instance, less information on vaping, but I'd say potentially a risk factor too, is that smoking seems to accelerate the loss rate of eggs to such a degree that women who are lifelong smokers tend to have an earlier age onset of menopause by a year or two compared to their other female peers, right? So something to keep in mind where you actually have some lifestyle control potentially if you engage in smoking on a regular basis to maybe kind of consider your egg supply. The red line shows, just see here, the risk of genetic abnormalities, aneuploidy. Aneuploidy means spontaneous, you put an egg and sperm together and you get, for instance, trisomy 21 or Down syndrome, or monosomy 3, or trisomy 15 or 13. Those kind of aneuploid concepti, the rates of those formations definitely increase as a woman's eggs age. And actually, there are graphs that doctors can actually share with patients that show as a woman ages from 30 to 35 to 40 to 45, the pretty dramatic increase in the rate of, even if they successfully can create embryos, whether naturally, without any assistance at home, if you're trying with heterosexual intercourse or with sperm insemination, or in a petri dish with in vitro fertilization, the marked increased rate of aneuploid embryos that form as a woman's eggs age from 30 to 40 to 45 and beyond. Right, so it's a combination of normal changes in quantity and quality. Now, with that said, I want to pause right here and first dispel a myth, because I know that some people will say, oh, I heard there is a test that can help predict my fertility and everything seems fine. And the answer is there's no test that can predict that. There are ovarian reserve tests, and most REIs nowadays will go and use a blood hormone test that some of you might be familiar with, AMH, anti-Mullerian hormone. And it seems to be a very good, kind of like a good rough estimator of your egg quantity. Although the caveat is if you're on hormonal suppression, like a birth control pill, it can actually transiently, birth control pill usage does not make your eggs die off faster, but it can suppress AMH expression. So I have seen some individuals who come to see me in the past where their AMH was, let's say they're 30, came in a little bit low for their average age category reading of like maybe it was 1.5 or 1. And they were a little freaked out. And I say to them always, having a low AMH without any kind of infertility history doesn't mean you're going to be infertile now or in the future. But for those who are on hormonal suppression, I might say, if you can stand it, you may want to come off that hormonal birth control pill for a few months and obviously use other contraceptive items to protect yourself if you're sexually active. And then let's redo your AMH in a few months. And lo and behold, in many cases, we'll see that AMH level jump up, not because a person has suddenly created fresh new eggs, they're not a unicorn, but that suppression effect on the AMH expression has gone away after the pill has emptied their system. And it takes sometimes a couple of months to see that rebound effect to get a real true assessment of that person's AMH, all right? But again, having an AMH level is not a predictor per se of your fertility. It just gives you and your physician a crude sense of your current day egg supply. That's it. Similarly, sometimes doctors will use a vaginal ultrasound to look at the ovaries. You can't see the eggs because they're micron small in diameter, but you can see some of the nascent antral follicles, those little honeycombed black spaces. If any of you have done a pelvic ultrasound or undergone a pelvic ultrasound, they look like little chocolate chips in the hyperechoic and the white ovaries. And those little chocolate chip spaces are little honeycomb spaces, follicles where the eggs are hunkered down in. So typically more antral follicles, 2 to 9 millimeters in diameter, represents typically more eggs, right? And again, there's not a good or bad number, but generally, the doctors will use AMH and follicle count to get a crude sense of what's going on with your egg supply. And that's useful for those of you who are thinking about undergoing fertility treatments because you have an immediate infertility need now, and so you need IVF, or you're contemplating egg freezing. right? On the male side, there's no hormone test per se to predict male fertility. The test that physicians still use, again, it's been around for decades, is a semen analysis. And with a semen analysis, what happens is typically those of you who are producing sperm would make an appointment either with a urologist or a reproductive endocrinologist. Some people will do it at a local sperm bank. I typically counsel men, if I see them, to try to abstain for about 2 to 5 days before they do the sperm analysis. And if they've recently been ill, like super sick with the flu or bad case of COVID with a high fever for several days, or let's say you went recently vacationing and sat in a hot tub every night for a week, that kind of localized high heat exposure can temporarily cause sperm counts to drop. And then over a month or two, they tend to rebound to your baseline levels, right? So things to consider if you're thinking about doing a sperm test. And then with a sperm test, the andrologist will take the seminal fluid that you give them in a cup. They process it and they look at an aliquot of semen under the microscope to count the sperm they see, to see how well they're moving. Are they swimming in circles? Are they swimming with a good sense of direction? And what their shapes are, their morphology. All right, let's move on to the next slide then. All right, so going back to that initial slide that we shared about why is there a higher prevalence of infertility amongst female physicians? So I already talked to you about how age affects egg supply and egg quality at a normal pace. So you can imagine how with the demanding education, it's not just 4 years of college, it's 4 years of med school plus 3 to 4 years of residency. And then if you do a fellowship, 1 to 3 plus more years. And if you do surgery residency, it's even longer plus fellowships. So it's a demanding education, it's a work hours, it's delaying the childbearing, all of which can contribute to later age infertility. There are some studies also looking at really busy on their feet physicians, like surgeons who are standing for many hours, and does that potentially contribute to infertility and miscarriage? Again, more studies need to be done, but there's a suggestion there may be a higher prevalence because of that sort of grueling work schedule and workload. Discrimination in that it might feed into a female physician being a little more secretive and maybe potentially delaying when she decides to start her family because she's afraid that she might not be able to advance in her career. I will say I didn't face that kind of discrimination, but I trained as an OB/GYN resident several decades ago. And again, I was working with a bunch of excellent physicians, and yet still, when I went out for my second child, when I was a new attending, and I came back after just 6 weeks of maternity leave because I was busy studying for the boards. Some of my male colleagues were like, "Oh, how was your time off? Are you well rested?" And I was like, "Are you kidding me?" But of course, that was a thought bubble in my head. I didn't really say anything out loud, right? So there's some external work factors that might influence how somebody might decide to plan their family. And then there's also potential for increased OB complications. Unfortunately, as I alluded to earlier, when women defer starting their family to a later age, the miscarriage rates go up due to aneuploidy. And with advanced maternal age, 35 and above, advanced reproductive age, there are higher rates of preeclampsia, cesarean section. That might also be slightly compounded as well for those who are conceiving with assisted reproductive technology, if needed, although that still kind of is somewhat debatable. And again, miscarriage rates go up with normal aging because of the aneuploidy effect on the eggs and the embryos that result, as well as potentially some soft studies suggesting that arduous workload of residents and fellows, especially in the surgical fields, might potentially put them at higher risk for miscarriage. All right, next slide, please. So what can you do now? One, as I wanted to sort of stress before, although I got carried away talking about eggs and sperm 2 slides ago, is I wanted to sort of lay the basic groundwork of how normal female and male physiology work when it comes to reproduction. But I also want to stress to the fact, for those of you with ovaries with eggs, that just because you defer trying to have a family at age until 35 or 38 or 40 does not mean that you're going to necessarily be doomed to infertility. We see plenty of females who into their 30s and 40s manage to conceive without any assistance, but you want to be smart about it. So if you are in the throes of trying, common sense things to keep in mind that oftentimes gynecologists may not have the time to remind you of. If you're trying it, if you're under the age of 35 with regular cycles, and if it's been close to like 6, 9 months, almost a year of unprotected intercourse at home with a male partner, no conception, I wouldn't panic. But then I'd say, you may want to start thinking about seeing a physician. And if you're over 35 and above, just because of that age factor, you may want to start thinking about getting specialist advice and help after just, 4 to 6 months of trying. I'll get that appointment squared away while you keep trying, right? And the reason why I'm saying this is it might seem obvious to this crew, but I can't tell you how many patients I've seen in the recent past whose own OBGYNs had told them after 1 year, oh, just keep trying. You just need to relax more. Give it a little more time before you see a specialist, right? And then lo and behold, they're 39 seeking help. So if family building is a priority, even if it's not an immediate priority, maybe in a few years, focus now on a healthy lifestyle. I mentioned how smoking can potentially accelerate the loss rate of those really precious eggs. Trying to eat healthy now, particularly for those of you who have erratic cycles in association with polycystic ovarian syndrome, for instance. Eating sort of more of a healthy Mediterranean type diet might actually help, not only with weight maintenance, but with hormonal regulation, as it helps with weight maintenance in those cases where PCOS and higher BMIs are correlated with menstrual dysregulation dysfunction. Really important, I think a lot of us physicians, especially while we're training and just trying to get this all done, make sure you're prioritizing your mental health. I know that for our progeny members, not only does our PCA team and each member gets assigned their own progeny care advocate to walk them through the whole process, not only to navigate the benefits, but to connect them with the right provider in their area and provide essential mental health support throughout the whole process, right? Because it can be very bewildering and stressful, I think, especially more so for those of us in healthcare. Know what your family building options are and know when to see the appropriate specialist, right? So I can spend another series of hours talking about, for those of you who have immediate family building needs, what that might look like. It might range from adoption to if you're, if you already know that your eggs or sperm are not really functioning very well, potentially donor egg or donor sperm usage. For those of you who are like same-sex male couples or a single male male parent by choice, it might be a combination of donor egg with sperm with a gestational carrier. So there's a whole myriad of choices and options available to help people of different backgrounds get to the point of having a family, the family that they want, and also know when to see the appropriate specialist. And the reason why that's really, really important is just one case in point, actually multiple cases in point. Sometimes I would see couples where, I'd ask both of them, I always talk to them about their own personal medical history, surgical history, family history, reproductive history. And sometimes the male partner might come in and say, no medications, no medical history. And then I would get a sperm analysis back on that person a week later. And I'd be like, this person has like less than 1 million sperm, but he told me he's not on medications, he looked healthy, he had a clean bill of health. And then when I kind of call him up or talk to him about his results, he's like, oh yeah, I saw this urologist, so I didn't think it was a big deal already. And he or she noted that my testosterone levels were a little low because I went to see them for low energy. Right? Oftentimes high performers will see a urologist, for that kind of sort of need, low energy. And so they put me on testosterone. And invariably what happens is that testosterone works almost like a temporary contraceptive item. So I've seen a number of male patients over the years where a urologist who didn't have the fertility education and background inadvertently actually gives these male patients a contraceptive. And then it takes a while, sometimes months, to first work with a reproductive urologist, pull them off the testosterone, and then hopefully see sperm production, spermatogenesis rebound and come back. So again, know when to see the appropriate specialist. If we can go to the next slide, please. So reasons to potentially see a fertility doctor. I kind of went over some of the trying to time length intervals, but there may be situations where kind of more immediately that you might need more help from a reproductive endocrinologist, for instance. So somebody with polycystic ovarian syndrome, you come off the pill and you realize, and you've known all along, that's why you went on the pill in the first place, that your periods come like once every 2 to 6 months. You might not want to wait a year before seeking help because you might need a little bit more immediate help to try to get your cycles regulated, to try to work with ovulation induction if you're trying to start having a family now or build your family. Patients who have undergone past cancer treatments or chemotherapies that are oftentimes used for other non-cancer related medical conditions like lupus. Some of those agents might put you at higher risk for premature ovarian insufficiency. So again, in that kind of situation, you may want to see an REI, reproductive endocrinologist, sooner than waiting for 6 months to a year after trying. I oftentimes will counsel and see patients where they say intercourse at home is basically impossible, either because it is so painful I cannot have intercourse to try to conceive, or my partner has a lot of erectile or ejaculatory dysfunction issues, so he can't ejaculate inside me. And so those situations, you may want to seek specialist help sooner than later. And then I talked about recurrent pregnancy loss and all the other options available for couples who are single, for individuals who are single parents by choice, or couples in the LGBTQ plus community who want support. Next slide, please. So I think I talked about a little bit about this already. I'm going to skip over to try to get us to the Q&A. But actually, let me just, sometimes it can be, I think, very difficult for a physician to become the patient. And so just so you know, if you decide to see an REI, this is what you might expect to happen. They might send you a questionnaire digitally to fill out beforehand. If you've had prior testing that's pertinent, like a pelvic CT or MRI, because you've had chronic pelvic pain and suspected endo, or an ultrasound, you may want to bring that. If your GYN has already done a recent AMH or TSH or prolactin, you may want to bring that in as well. And they're going to talk to you about your medical history, your social habits, your family history, surgical history. They will also offer to do a vaginal sonogram to do that antral follicle count and to look for any obvious uterine pathology, potentially like adenomyosis, fibroids, things that might make it a little more difficult for you to conceive. And then they might also, if you haven't already done so, order some blood work and hormone testing. Now, if you're actively trying to conceive and you're seeing an REI because you actually suspect you have infertility, and you go in with a partner, and that partner has sperm, you have eggs, your physician, if you haven't already done so, might also offer you expanded carrier testing to see if the two of you have any overlapping autosomal recessive, X-linked genetic traits that could be of concern should your child inherit both genes. Next slide, please. And as I alluded to earlier, for individuals with sperm, it's a sperm analysis. Most fertility clinics nowadays, thankfully, have private rooms specifically allotted for men to do sperm testing, to produce sperm for procedures like insemination treatments and IVF. And, I understand it can be a little stressful. Not to worry, the team there is very supportive and very sympathetic. It's a private room. You get a specimen cup similar to those urine cups that you give to patients to do urine sample, and then you're left alone. And once you ejaculate the specimen, the andrologist will take it and analyze it, and typically can take up to a week for the andrologist to spin out the report, have the physician review and sign off, and then their team will connect you with the results and go over the results. For some individuals, it is really, really difficult to produce in the office. So in certain instances, talk to your physician in that case about potentially getting permission to produce at home. The physician's team can provide you with an at-home production kit, and then you bring the specimen in. Next slide, please. All right. So wanted to go over one of several options. I oftentimes will see professional women, physicians in training, other professionals who are very mindful of how delaying family building because they were focusing on their career might affect their future fertility. So they want to have as many options in the future as possible. So they'll come to see somebody like me to talk about egg freezing. I don't like using the term elective because it's almost like you have a choice there, and it's more like you're trying to give yourself as many real future fertility options, knowing how age can affect your fertility. But this is egg freezing, and it's going to look the same for egg freezing for those who need it because they're about to embark on therapy for breast cancer, for instance, and their oncologist is saying, listen, the chemo that we're going to put you on in a month is going to potentially put you in premature menopause. Do think about egg freezing and pursue it now so you have some eggs stashed away just in case. So regardless of the reasons that draw you to egg freezing, the consultation is typically with a reproductive endocrinologist. So somebody who's done 4 years of OB/GYN residency and graduated, and done 3 years of REI fellowship and graduated. And they'll sit down with you, or the team will sit down with you, depending on the structure of the clinic. They'll go through the history, they'll do an exam, potentially like all the other testing I mentioned 2 slides ago. And then using the information from your AMH, your follicle count, your REI will craft a protocol of gonadotropin stimulation to suit your ovarian needs. And so the other part of the discussion is, especially for busy residents and fellows who have very inflexible training schedules, to try to figure out how do you shape this around your training schedule. So we'll typically talk about, when do you have your next elective block, or when do you have some upcoming time off from your residency vacation where you might be able to fit this in. Because from the time you start the gonadotropin injections to wake up those eggs to the time of the egg harvesting retrieval, it typically will take people around, I'd say, 12 days, 14 days. And for the majority of that time frame, the vast majority of patients keep on working. But obviously on the day of egg retrieval, because it's a minor procedure that takes place typically in the office in the IVF clinic, under propofol sedation with a little bit of fentanyl, typically under the care of an anesthesiologist while the REI is harvesting your eggs. And the procedure itself takes about 15 to 20 minutes. You definitely don't want to be back at work in the hospital the same day. You want some time to go home, rest in bed, sit on the couch, because you are going to have some soreness afterwards. Although the majority of people are typically back at work the day after the procedure, right? And really important, you want a trusted friend or family member, some adult chaperone, to help escort you back from the clinic post-retrieval back home and help you out if you need like help getting takeout or kind of getting yourself tucked up into bed. All right. So the stimulation typically starts around the 2nd or 3rd day of a menstrual cycle. That's typically where your hormones are in your nadir. And so this is a good time to sneak in gonadotropin stimulation to kind of wake up those immature eggs to get them to mature. There are sometimes situations when it may be appropriate to better jerry-rig around your work schedule, where your doctor might say to you, oh, in your case, it might be appropriate for you to start an estrogen patch about a week before your period starts, so we can have a little bit more control over when you start your medications. Or in certain cases, put you on a low-dose birth control pill for a week and a half, 2 weeks, to give you further control of scheduling, right? Again, not appropriate for all patients doing this, but sometimes can help around that very stressful, issue of how do you schedule all of this. The injections, once they start, imitate the same anterior pituitary hormones that your brain makes, FSH and LH, but they come in sub-Q form. Some physicians will have you dose it once a day. Some physicians will do it twice a day. It kind of varies a little bit clinic by clinic, and the dosing amount varies based on your ovarian reserve. Typically, people who have lower ovarian reserve might be given higher doses of these regimens, whereas those with higher ovarian reserve probably, in general, need less stimulation, so you might start with lower medication doses. Most people find that the injections themselves are tolerable. It's a very small needle. Sometimes there's a little bit of localized redness and itching, burning that dissipates within a few minutes. Some people will find that as the gonadotropins work to wake up their eggs and as their endogenous estradiol levels go up, they might sort of experience some of the effects of the rising estrogen levels. So some people will say, wow, my mood is much better. People are telling me at work that I'm less grumpy. Some people will say they get a little bit more cranky or tearful. Some people will say that they're feeling a little bit more energized, right, and organized from all that estrogen. Some people will say they feel more sleepy. Some people will note things like increased breast tenderness, as well as increased vaginal mucus discharge. Some people will note that they've, gained a little bit of temporary water weight by a couple of pounds. Some people don't gain any weight. And some people will say they feel a little bit bloated as they get closer to the time of retrieval as their eggs recruit and mature. And I've had other patients say they don't have any symptoms whatsoever. Some people who are migraine sufferers say that their migraines get better, but then after the retrieval, as their estrogen levels drop, their migraines get exacerbated. So it can vary from person to person, right? The egg retrieval, I don't know if any of you have witnessed an egg retrieval or observed one. It's kind of a neat procedure. It is invasive. It involves a 17-20 gauge angle tip needle that goes through the vaginal sidewall directly into the ovaries with direct visualization from a vaginal ultrasound to guide the needle into the follicles. which kind of makes sense for why you want to be under sedation. Ideally, you don't want to be moving or awake for this. And when you wake up, obviously the needle is gone, the ultrasound probe is gone, but it's not unusual to have a few days of vaginal bleeding, staining, spotting from the punctures. It's not unusual to have a couple of days of some pelvic pain. Most people find that it's manageable with over-the-counter NSAIDs. Some people need a little bit more. I've found in the past that people who have a history of chronic pelvic pain, severe menstrual pain, endometriosis pain, oftentimes might benefit from a little bit more pain management around this time. So, talk to your physician if you have concerns. And then a lot of people will find that they have a lot of bloating that kicks in about 1 to 2 days after the retrieval. Bear in mind that typically before you even leave the office, your physician or embryologist will come out to you and tell you how many eggs were harvested, although they will not be able to tell you how many of those harvested eggs were usable and freezable, like mature, until the following day. Rule of thumb is like 50 to 80% of the harvested eggs end up being mature and stuck in the freezer. And so typically, again, depends on the clinic culture. They'll either communicate with you via their portal, or someone will call you and tell you the next day how many eggs were actually frozen. Once the eggs are frozen because they're vitrified and liquid nitrogen, they can stay frozen indefinitely. Several decades ago, when egg freezing was being introduced, there was concern that if you froze eggs for too long a duration, that might degrade their quality. Their recent studies have shown that it's not the case. So they basically sit in the freezer and the nitrogen tanks until you're ready to use them. And if you move around, another question that gets fielded oftentimes is, well, I'm training here in like Pittsburgh, but I think I want to relocate and move and set up practice in Southern California. What do I do about my eggs? There are different ways to approach it. Thankfully, there's a whole national network of different clinics, and it's not uncommon for members to actually, for patients to transport and ship their gametes, whether eggs or sperm, to a different clinic for storage there, so they're more locally available. And your physician and lab can help you with that, right? This kind of process is fairly similar up until the retrieval if you're trying to freeze or create embryos. The difference is if you're creating embryos, you need sperm, either from a partner or donor source, to fertilize the mature eggs within a petri dish in the embryology lab. And then the different updates are such that the day after the retrieval, the embryologist or physician or nurse from that clinic will inform you how many of the eggs were mature and how many of the mature eggs fertilized. And then typically about a week from the retrieval, they'll let you know how many of those fertilized eggs turned into embryos. Not uncommonly, a lot of patients will elect nowadays, especially if they don't plan to use those embryos for several years, to do genetic screening on the embryos for things like spontaneous aneuploidy, like trisomy 21. So sometimes patients will elect to do PGTA, pre-implantation genetics testing for aneuploidy. And if that's the case, about 3 weeks, 4 weeks after the retrieval, your doctor's team will then notify you, hey, we got the PGT results. You had 12 eggs, 8 were mature, 6 fertilized. Of the 6 fertilized eggs, you got 2 embryos. Of the 2 embryos, both are euploid. One's male, one's female. They're good to be used in the future. That's it. Or, hey, you had 3 embryos tested. 2 of them were aneuploid. Not surprising because you're 39 or 40. You have 1 euploid. So you have 1 usable embryo for future usage. You can layer on top of that. If you're doing genetic testing, let's say you walk in the door and you say, I know I have the BRCA gene, and I know this because all the female members had breast cancer before the age of 50, which is why I tested myself. Can you screen the embryos with PGTM for BRCA? And the answer is yes. So you can get that additional layer of information. It just takes a little bit more time to get into the information, right? And a little bit more planning. But that's the other kind of information you get on these embryos if you create embryos, not on eggs. Eggs, you need to first take those eggs, create embryos with sperm, and then you can do genetic screening on the embryos. Next slide, please. All right, I think that's it. And, open to all sorts of questions. We'll try to answer them if I can. And thanks so much for listening.
Thank you so much, Dr. Choi. We really appreciate your expertise. I wanted to flag before we begin our Q&A portion, folks correctly pointed out that the link to the benefits portal does direct you to the Bellevue Hospital in New York City, and that is obviously not correct for everybody.
Oh,
So instead, I will be dropping in the chat a link to the member portal, which should allow you to access your contract information and some more information about benefits. I also wanted folks to know that the CIR website is undergoing some sort of revisions at the moment, so things should be updated soon, and you can always reach out to your contract organizer for specific questions. So in just a minute, I will drop the link to the member portal, and then we will go on to our Q&A portion. Um, Please direct your questions to the Q&A window. You can see other folks' questions as well. And please feel free to upvote those that you find most relevant so we can know the order to answer them. But the good news is we don't have an overwhelming number of people, so we should be able to get to these. And Dr. Choi, is it correct that we have until 7:30 p.m. for questions?
sure. Although, yes, I'm happy to stay on as long as necessary, but I also want to be respectful of the audience time, so
Thank you.
we can close whenever you want to.
That's generous. Thank you. So the first question we have from the chat, is there a certain age where you should no longer consider freezing your eggs? For example, 33 years old, but plan to try conceiving in 2 to 3 years.
So that's a great question. Is there an absolute age cutoff? Nowadays, I think the answer is yes, although I think you have to do the risk-benefit analysis, right? So for most individuals who are age 33 with eggs, 35 even, reasonable age, because when you look at the curves there, most individuals, not all, will have a decent supply of eggs of adequate quality, meaning potential for creating euploid pregnancies, that it may be worth the risk, which is small, of going through an egg freezing cycle, versus say somebody who's 43, right? So, another area that I've been focusing on of late is menopause. Average age of menopause is around 50, 51. Perimenopause can start to kick in even in one's late 30s, early mid 40s. And although I have seen and actually taken care of women who have come in their early 40s to seek egg freezing because they're not quite yet ready to have a family or start having a family, I've always warned them about the expectations that egg freezing is never 100% guaranteed that these eggs are frozen, even if you freeze them at age 25, that they're going to work. Some of them don't survive the thaw process. Some of them just don't turn into fertilized eggs or embryos. But the likelihood is further reduced when you're dealing with eggs in lower quantity typically, and normally age-impacted quality at age 42, 43. So ideally, what I counsel patients, and I think most specialists do the same, is if you're thinking about egg freezing, the best time to do it is now or as close to now as possible.
Thank you.
Yep.
The next question. What is the best way to get in touch with our hospital's OB/GYN/REI department to begin the process?
So I think the best way would be is first find out who is in network. Now, if you happen to have progeny and that's in network, that's a provider for you, then I would onboard with your progeny PCA, and they can actually help you figure out who are the REIs in your vicinity, whether it's like work proximity or home proximity, and whom can they help you connect with so you can get an appointment. Now, bear in mind that those of you who do have the progeny benefit do have fertility preservation, from what I'm understanding, Clara, for medically indicated fertility preservation. So for those of you who are undergoing treatment for either impending cancer treatments or embarking on treatments for gender dysphoria, right? And in those situations, because time is of the essence, oftentimes you can get connected with an REI, in your network within a matter of a few days, right? Now, if you don't have progeny as your benefit provider, check with your medical insurer, or if you already have a gynecologist whom you see. Some gynecologists love this stuff, although at least in New York City, most gynecologists are so busy dealing with GYN-related issues as well as OB issues, they'll say to us, please take our fertility questioning patients off our hands and see them. But some do, and you can always say to them, hey, I just want to get some basic fertility testing, ovarian reserve testing. Could you do that for me? Understanding what I said before, which is there's no test that's an absolute predictor of your fecundity or your ability to conceive. It's just kind of a crude snapshot of your present day egg supply. And if you think you might act on that, then maybe get that testing done. But those are different ways to try to access care.
Thank you.
Yeah.
Next up, is there a BMI limit when it comes to freezing eggs? How does BMI affect ability to harvest eggs?
So that's a really great question. Many clinics, because they operate and their retrieval rooms operate in an outpatient setting, albeit with teamwork with an anesthesiologist, many clinics may have a BMI cutoff. The clinic that I worked in, our anesthesiologist rotated in and out of our clinic as well as the hospital. And they had an interesting approach where they said, we care less about the BMI, it's more of the airway, right? How accessible is the airway? Because we want to just make sure we can keep your patient safe in the outpatient setting. But the BMI range cutoff could be anywhere between 40 to 50. And that doesn't necessarily mean that exceptions can't be made. But the reason why BMI is an issue, again, is airway safety issues, especially in the outpatient setting. Should you, even though it's under monitored sedation, have an airway issue, and it does occur. And it can also make it sometimes more difficult to harvest the eggs. When patients have a higher BMI, not always, but sometimes. And in certain situations where patients are really committed to the idea of pursuing egg freezing IVF, I know that my colleagues will sometimes work with weight management specialists to try to maybe, if they can afford to take the time before going into fertility preservation or IVF, to work on, lifestyle. Nowadays, GLP-1s come to the forefront for about, 3-6 months to try to lose some weight to make the whole process safer, and then come off the GLP-1 and start a retrieval process.
Next up, how long would you expect to conceive if 14 months PP and completely weaned breastfeeding 2 months ago? 33-year-old female, no PMH, conceived first baby in first month of trying. At what point should I consider seeing an REI? After 6 months of TTC?
That's a really good question. And some of this kind of comes up with, let's say I'm going to go with the hypothesis that let's say this person has regular cycles, suggesting that they ovulate without any kind of external stimulation or induction. Let's assume this person had a vaginal delivery, non-surgical delivery. And in that case, and no galactorrhea, sometimes you might have weaned, but you might still have elevated circulating prolactin levels, which actually can inhibit ovulation or make it less reliable. But assuming all that's okay, thyroid function is normal, also not affecting ovulatory function. If you're having fairly regular cycles, I would say potentially and an uncomplicated vaginal delivery without any surgical instrumentation, I'd say, knowing that it can take a while to get in to see an REI, knowing that it can be hard to coordinate that with your work schedule and your home life family schedule, especially with a newborn toddler, you may want to think about starting to at least pick up the phone, make an appointment at around the 8 to 10 month mark, so that let's say by the time you get in to see the doctor, it's close to a year. You're still not in a panic, but you have a next step already underway, right? And for me, the happiest situations are when I see a patient and we have a discussion, and then they call me back 6 weeks later and say, I did the testing, but I'm pregnant on my own. Thanks so much. Now, if you had a complicated delivery, particularly if it was a complicated cesarean section, sometimes, not always, you might have some other issues arising because of that. And so then you may want to think about if you're someone who gets a little nervous, a little concerned, you notice your menstrual patterns are a little bit different from pre-pregnancy, then you may want to think about seeing an REI sooner, right? Maybe for an SHG, say an ultrasound, things like that. But that's not a hard and fast rule.
Given the new contract, how can we better understand what costs look like for this? And I understand, that is probably specific to the specific contract that this member falls under. And so, Dr. Choi, feel free to answer as given progeny, but I would also recommend for this member to check out the benefits portal and also reach out to our benefits team, as well as their contract organizer. But go ahead, Dr. Choi.
I would, and I would probably say, because I don't want to, because there are different tiers. You have to think about copays and deductibles and things like that, right? And then I don't know, Mary Kate, who's posing as me, because I invited her to this. She's your benefit liaison at
Hi
Progeny.
there.
If there's anything else you can add there.
Um, I would second what you said, Dr. Choi. Typically the way it would work with Progeny is depending on the medical plan you're on, the coinsurance or copay, and up to the out-of-pocket maximum would apply up until you meet your out-of-pocket maximum. If you are eligible for Progeny, you can contact your patient care advocate and they can actually walk you through what the expected out-of-cost would be based upon the plan that you're enrolled in. If you're not under the Progeny plan, then would similarly recommend checking out your benefits resources, just to see what the coverage looks like based on the medical plan you're enrolled in.
Thank you. And would you please also, I know you just answered that question for us, would you give us a little bit of context? Is it Mary Kate, into your role for CIR members?
Yes. So I'm a member of our client success team here at Progeny, and I will be supporting CIR during the implementation and once the benefit goes live. So been with Progeny for about 6 years, and really thrilled to be bringing this benefit to you all.
Thank you so much.
Of course.
Next up, what are risks and benefits of egg freezing?
So I will try to address some of the risks, the risks that patients will come to me asking about. They'll say, I'm worried about doing egg freezing because I'm worried it's going to deplete or accelerate the loss rate of my eggs. Because if you're taking out 20 eggs, that means I'm now deprived of those 20 eggs. Am I going to hit menopause 20 months younger? And the answer is no. There have been studies that have been done. Because bear in mind, due to the fun apoptosis attrition, we're not just losing one egg, even if we're ovulating each month, we're losing a whole myriad of other eggs. And so the eggs are programmed to disappear, whether you harvest them or just leave them to their own devices in your ovaries. So that's one myth or concern that gets voiced or asked about a lot. Another question is by taking these gonadotropins and revving up my estradiol production as these eggs recruit and mature for this egg freezing cycle over 2 weeks, am I somehow increasing my risk for breast or ovarian cancer? And again, there have been a number of studies that have been done over the decades since IVF was first introduced in the 70s. And the good studies that have been done, population-based studies, have not shown a real increased risk for either of those concerns, like cancer-related. Now, short-term risks, I'd say, for some individuals, not all, hyperstimulation syndrome comes up. And I don't know if some of you have managed ER patients who come to the door post-retrieval a day or 2 or 3 days after their trigger, 5 days after the trigger. When they end up third spacing fluid, their ovaries are huge. They're up from their typical resting size of 2 to 3 centimeters in length to like 8 to 10 centimeters. And there's like ascites everywhere. They might have, potassium, sodium disruption, hemoconcentration, LFT elevation. That kind of severe, moderate to severe hyperstim, those rates seem to have gone down over the past few years because there have been changes in available medications doctors have at their hands to help trigger the maturity of those eggs. So oftentimes nowadays, people who are at high risk for ovarian hyperstimulation, doctors might dose them only with Lupron, GnRH agonist sub-Q shots to trigger those eggs and get them ready for harvest to get them to mature. Sometimes doctors will do a combination of Lupron with very low doses of HCG. HCG seems to be the culprit here because it has a very long half-life. And so oftentimes what the doctor will do to try to mitigate someone's risk for hyperstim is maybe give them a whiff of HCG, like 1,500 IUs, 2,500 IUs, as opposed to the full 10,000. But hyperstim is still discussed. Ovarian torsion can still be a risk. Again, we're only talking about a percent point or two, but this is the reason why doctors oftentimes will counsel patients as your ovaries enlarge in size in response to the gonadotropins. And then for about a week or a week and a half until week and a half post-retrieval, your ovaries are still going to be rather edemic, puffy, swollen, enlarged in size, and so more prone to flopping around and potentially torsing. And that's why we counsel patients to try to ease up, back away from doing your typical, HIIT, workout, or Barry's boot camp or Soul Cycle. and do something a little bit more low key, like walking on the treadmill if you're dying to exercise. Trying to avoid intercourse also, because you don't want to move around those ovaries, right? Infection, lower rate risk, is pretty low, like less than 1%. Bleeding, again, fairly rare. But again, that's why it's important when you discuss your history with your physician that you talk to them about if you have a long history of menorrhagia or hospitalization for transfusions. We want to know about that. We want to know if you have von Willebrand so we can then coordinate with your hematologist so you get the proper medications around the time of retrieval to minimize the risk for bleeding.
If we are hoping to egg freeze and currently have an IUD in place, how long before we should remove the IUD?
That's a great question. There was a study. So IUDs are levonorgestrel agents, synthetic progestin. And there have been some studies performed on egg donors and egg freezers who are young with a appropriate egg reserve that have said that leaving a Mirena type Kalina IUD in place does not seem to impact the egg retrieval yield for a young egg freezer. So again, I would say, knowing that, you probably don't need to take it out, but I would just raise that to your REI should you consult with an REI. Obviously, for a copper IUD, because it's non-hormonal, you can keep it in place, but just anticipate that estrogen is a stimulant, not just is a stimulant in different tissues, causes your endometrium to build up. So oftentimes people will be like, oh, I have like very scanty periods. And I'm like, well, just be prepared. That week or two after your retrieval, when you do get your withdrawal bleed, as your estrogen levels drop, might be heavier than you're used to. So sometimes people with a copper IUD, people with menorrhagia history in the past, to just warn them, anticipate it might be a heavier than expected period.
If there's any genetic abnormalities in the harvested eggs, are they detected?
So again, remember, the eggs contribute half the chromosomes to a developing embryo. You get the other half from the sperm, and then they combine to make a genetically unique embryo and individual. So you can't really do any kind of meaningful genetic testing until you get an embryo. But that's where you might be able to apply genetic testing if you know what genetic mutations you're looking for ahead of time, right? So sometimes people will ask me, because they're really savvy, oh, can you look for spontaneous mutations that occur that lead to like autism, because I'm really worried about it. I'm like, if you have a known mutation in your family that we can test for ahead of time and have the genetics lab create a marker to apply to your embryo samples, then yes, we can. But we can't look for de novo right now.
What is the cost of egg retrieval, IVF, and genetic testing of embryos?
So again, it's really going to vary in terms of the degree of coverage you have. I will tell you that if you're all in completely cash pay, for an egg freezing cycle, at least in the New York City area, you're probably looking at medications, medical therapy included, probably around $10,000 to $12,000. Correct me if I'm wrong, Mary Kate. For IVF, so that includes sperm processing and embryo freezing. Plus, if you're going to layer in that genetic screening, then you're looking at closer to like $18,000 to $20,000, right?
That's correct. Yep.
Right. And then the storage to keep those embryos. It's not like you can stick them in Manhattan storage and forget about it and pay $100 per year. It's oftentimes most clinics will charge upwards of about $1,000 per year for storage after the first year.
What are the pros and cons of freezing eggs versus embryos if someone doesn't have a partner to give sperm yet?
So the technology around egg freezing is a little bit more delicate than embryos when it comes to freezing. It's taken a lot more technology and research to really kind of make freezing a viable option, because you want to make sure not only that the eggs freeze properly, but that they survive and thaw. And so historically, because of the very high water content in their ooplasm, eggs were trickier to freeze. The technology that lab people use, embryologists use nowadays, is called vitrification, where the eggs are flash frozen. Same technique now applied to embryos as well. And typically in a good lab, embryos that are created when they're frozen typically will thaw and survive 99% of the time, right? I would say eggs in a really good lab probably end up surviving the thaw 90% of the time. But this is the reason why, but that's much better than it was several years ago when it was like 60%, 50%, 70%, right? There was a lot of attrition during the thaw process. So it's not like one is better than the other. but the way I approach it is you're making yourself go through this now so you have for you yourself options. So if you are single or your partner with someone where you're like, oh, I'm not really sure where this is going, then I would counsel you to do egg freezing. Even if you're in a really solid, loving, meaningful relationships change. And I've taken care of couples where sometimes, the wife, right, or the female partner might say, hey, I actually love my partner, I love him, but just in case, I want to freeze eggs as another safeguard. Because in that case, you then have full autonomy of how to use those frozen eggs, when to thaw them, which sperm source to use in the future. With embryos, and there are disposition consent forms you have to sign with your doctor's team before you start the process. With embryos, you're beholden to the person who donates their sperm with you, right, to create those embryos. And you're beholden to them, unless you're using anonymous sperm donor sperm from a sperm bank, on getting their future consent. Once you're ready to use those embryos, you need to find that person if you're no longer with them, extract consent from them. And I can tell you in most cases, if the relationship has shifted and dissolved, that ex-partner is not going to consent willingly, right? Because they bear a lot of parental responsibility and duty if they consent to you using those embryos. So the issue with the embryos is, you're relying on consent from you as well as your partner, hopefully the same partner in the future, to use those embryos. The benefit of freezing embryos is that, some of the eggs never make it to embryos. Some of the embryos never make it to pregnancy stage because oftentimes they're genetically imbalanced and abnormal. So if you end up freezing embryos, you get a lot of that upfront information now, right? So sometimes people will be like, I don't understand. You're telling me I have this genetically normal euploid day 5 embryo, and you're saying that it has like a 60–70% chance of a pregnancy, but you're telling me my one mature frozen egg has only maybe like a 5% or 3%. I'm like, yeah, because that egg has to survive the freeze or thaw, has to then fertilize, has to then spend 7 days in a petri dish, 5 to 7 days in a petri dish, to see if it even divides and turns into an embryo. Some don't, right? Reproduction is very inefficient. And then, if you decide to do genetic screening, it has to come up being, genetically euploid and usable before you use it, right? So there are a lot more hoops that the egg has to jump through that the embryo is a result of already, right? So again, not that one is better than the other, but these are the considerations you have to bear in mind.
This is a relevant next question. What are the general success rates for egg freezing and embryo freezing? You might have gotten to a lot of this, and the percentage of either that lead to healthy gestations.
So again, it's highly variable and dependent. A lot of it correlated with the age at the time those eggs leave the person's body and ovaries. Meaning, look at it this way. When I have patients whose ovaries and eggs are no longer cooperating, some of those patients will turn to adoption. Some patients will say, enough already, I gave it my all, I'm going to go just live my life. And some patients will turn to donor eggs. Typical egg donor age, where we use an egg donor who's compensated for their time and effort to donate their eggs, typically anonymously to other people who want to become parents now. Typical donor egg age is usually around female who's in their 20s, sometimes in their young 30s. Typical cutoff, though, is usually like young 30s or so because of the normal biology effect on egg quality and quantity, right? So in terms of success rates, it's going to vary and depend on the age at which you pursue the process. So let me answer it this way. If you have an embryo that looks exactly the same under the microscope, like let's say you have a series of 3, and they're 5-day-old embryos, blastocysts, you can look them up. They're cute little bubble, like fluid-filled, 100-cell embryos. And, all excellent grade just based on appearance morphology. And one is from like a 30-year-old egg source, one's from a 37-year-old egg source, and one's from a 40-year-old egg source. And then they start going through the process of getting biopsied for genetic, screening. The likelihood of the 30-year-old egg source embryo coming back euploid is probably as high as like 60–70%, right? 80%. The likelihood of the embryo created from the 38-year-old egg coming back euploid is 50%, approximately. Depends a little on the lab, but it's kind of general. The likelihood of the 40-year-old egg turning into an embryo coming back genetically usable is probably more along 20%, 25%. And then if you have a chromosomally screened usable embryo, right, likelihood of that embryo, assuming that you have a uterus that is healthy, normal, right? There's testing, your doctor's going to offer you to check out your uterus beforehand, and you don't have underlying endometriosis and other factors. Once the embryo goes in, then, the pregnancy rates, assuming that PGT has been done, and again, PGT is not required. Your doctor will talk to you about it as an option. Probably might be more of a useful tool for those of you who are thinking about not planning on using your embryos for like 5 years or so, and you want to know now, I have 5 embryos, but 2 of them are not usable, right? Or, someone with immediate fertility needs who's like 35 and above, right? Or history of recurrent pregnancy loss. So once you have that kind of genetic chromosomal information, and if they're all similar grade and quality, studies have suggested up until age 42, 43 of the egg source, pregnancy rates are relatively similar at that point. So typically in a good clinic, good lab, good embryology team, good lab technique, we're looking at, pregnancy rates probably on the order of like 50 to 70%. Right? Miscarriages can still happen because the PGT screening is not all seeing, right? It's a screener. But the miscarriage rates tend to be lower in general, like under 5-8%, 5-10%. So that kind of gives you a sense. Now, if you don't do genetic screening, a lot of it is really the likelihood of that embryo giving you a pregnancy really depends on the age of the egg source.
Thank you. At this time, we're about midway through our Q&A portion. We'll go until 7:30. Thank you again, Dr. Choi. I'm just flagging that I'm dropping in the chat our feedback form on this webinar here. This is our first time hosting a fertility webinar, and we would really love to know how we can improve the experience for you. So as we're continuing on with the Q&A, please take some time to fill that out. The next question for you, Dr. Choi. Is there an age at which you would recommend automatically starting with IVF with previously frozen eggs, say you froze them during residency, versus trying to conceive naturally?
That is a really great question that gets asked a lot. Keeping in mind what I said earlier, just because someone who's 37, 39, 40 doesn't necessarily mean that if they start trying to, conceive today, that they're going to encounter fertility issues and they may end up with a healthy child. Depends on your family planning needs, right? And your risk tolerance. Knowing that the rates of aneuploidy definitely do increase with normal aging. I think it's going to, it depends. If you're like, I just want one kid, I've already put the effort of freezing these eggs when I was 30 and I'm 38 now, only want one child, then you might want to talk to your doctor about using those 30-year-old eggs. But if you're of the same mindset and you're also like, I'd like to try to see if I can conceive and save myself some time and money and effort, and if you happen to have a partner with whom you can try to procreate, then give that, an attempt for a few months as well, right? So I think it kind of depends on your personal needs, your risk tolerance, and also family planning, because some patients will come in the door and say, hey, I'm already 36, I have these eggs, but I'd like to, with my partner, have ideally 2 or 3 kids. So maybe I should think about starting to try on my own now. And I'll say, yeah, and then keep those eggs in reserve for pregnancy number 2 or 3, or after maybe like 4 or 6 months of trying, re-explore the question of, do I use my frozen eggs? Do I combine them now that I have some infertility symptoms or evidence? Do I combine them with another cycle of IVF to get more embryos to use so that I can not only get pregnant now with, a diagnosis of infertility, but hopefully have embryos in the freezer for babies number 2 and 3 attempts.
How often do women have to do multiple rounds of egg harvesting?
That, again, I can't give you an exact percentage. It's going to depend. Again, oftentimes women, as we get older, because we typically, but not always, have pure eggs to work with, end up going through an additional 2nd round, sometimes 3rd round, after pausing and talking it over with their doctor and talking about what their desired goals are. Another question I get asked a lot is how many eggs do I need to guarantee a baby? And that's an unanswerable question. But typically, if you're doing this process in a younger age, part of your life, like in your late 20s or early 30s, general rule of thumb is if you're under 35, if you can get 10, 12, 15 mature eggs in the freezer, that probably gives you a pretty respectable chance, 70, 80, 90% chance of having a baby in the future, understanding it's still not a guarantee, because again, even the best eggs may not survive the freezer all the time or turn into usable embryos. Versus say somebody who is 38 trying to freeze eggs, you might need upwards of like 20, 25, 30 eggs, right, to get a similar estimated chance at a future live birth pregnancy. Um, Mary Kate can share with you when we've done our own internal analyses for our members compared to national averages, at least for the progeny patients who see progeny doctors, they seem to be getting to, at least if they have infertility now and are actively pursuing trying to get pregnant now, not just doing fertility preservation, they seem to be achieving pregnancy with 1 or 2 fewer retrievals compared to national averages. But that's just something, that our own internal data team is collecting.
This is a specific question. My wife and I are sickle cell carriers and know we need PGT-M to reduce the risk of SS embryos.
Yeah.
How many fertilized embryos is an appropriate minimum to have that done? Embryo biopsy.
So, talk to your provider, just because most providers nowadays and most labs, again, your physician is not in the lab dabbling. They're doing the patient-facing care, the clinical care, the testing, the ultrasound, the retrieval. It's the embryology team and the genetics team. And most labs that I'm aware of will typically charge you by the embryo or give you some sort of case rate per embryo. So understanding, the inheritance odds, like you don't need me to tell you this, I'm sure you already kind of agonized over this and thought about it. There is a 1 in 4 chance of you having an SS affected embryo result. And that means 75% chance of either getting, 50% carrier, 1 totally non-carrier, non-affected embryo. And so, when you get, even if you have 1 embryo, there's a chance it's going to come back as usable, right? So I don't know if I would approach it that way. The goal always is we're trying to help individuals, couples, get as many usable embryos as is healthy and as usable. But sometimes we're restricted, oftentimes, by how the eggs and sperm perform. Right? But that's my long-winded answer to, even if you know that your partner has a low egg reserve and you're only getting like 1 embryo at a time, still think it's worthwhile if you know that in your mind you definitely would act upon that PGT-M information to do testing, even if it's on 1 embryo. Understanding that I've actually met with patients in the past where they've said, for whatever reason, I declined the PGT. I hear your genetic counseling team advice. And, I'll take my chances, or I'll just do early pregnancy testing.
What happens with unused embryos?
It's totally kind of up to you. So there's some embryos that are already degenerate after a few days of living in the petri dish. They're like totally non-viable. So those are discarded. Again, IVF centers will offer you these consent forms and review them before you go through the process of embryo disposition. For those embryos that are considered non-viable, non-freezable, non-transferable, non-usable, do you want to donate them anonymously to research that's ongoing? Do you want to discard them? For embryos that you end up freezing that you never have to use. Thankfully, a number of people will freeze eggs or freeze embryos, freeze sperm they never have to use because they end up conceiving without any assistance, or their family building plans change as they get older. But with those potentially usable embryos that are sitting in the freezer, it again is up to you. Thankfully, at least at this time in all the states where you get to decide, hey, I'd like to discard those embryos or donate them to research, or some people will donate them anonymously to organizations so that individuals or couples who are struggling with infertility for whatever reason aren't pursuing IVF with their own gametes might be willing to take on a donated embryo to try to have a child. And I've seen some really wonderful results from that too.
That's
paying it
fascinating.
forward. Yeah.
Thank you. What factors in male partners' health affect the chances of a healthy pregnancy? For example, things like lack of exercise, improper diet, smoking, vaping, etc.
Right.
Do we know for sure these are definite factors that affect chances of a healthy pregnancy?
Well, listen, just like we've seen, those octogenarians, centenarians who've been like a pack-a-day smoker for 100 years and still are living, you're going to get some exceptions to the rule. But in general, one of the things I'll always counsel males if they decide they want my advice, and sometimes they don't, is if you're here with a female partner and you're seeing the struggle that she's going through, do your part. And so there are lifestyle measures that may potentially improve your sperm quality. Remember, sperm production, spermatogenesis is an ongoing process. Men, even in their 50s, 60s, 70s, are making sperm, right? It's about a 2.5-month life cycle. And so it's not enough. Like someone will say, oh, my partner's getting her retrieval done next week. I'll stop drinking today. I'm like, you should have stopped drinking a few months ago, right? Or I'll avoid, hot tubs, starting today. So, if it's tolerable to you, if it's not too much of a sacrifice, and I counsel, even if it's a little bit of a sacrifice, I'd work on trying to stay healthy even now. Even if family building is a little bit kind of further into the distant future, it's going to help your heart health, let alone your sperm health, right? And so trying to work on, if you're smoking, if you're using marijuana, if you're vaping, trying to cut those back, reduce using them altogether. If you're, consume alcohol, I can't tell you how many times I've seen sometimes male factor infertility show up. We tried everything. Sometimes even IVF with ICSI doesn't work. ICSI is when the embryologist can actually literally take one sperm at a time and micro-inject that sperm into an egg under the microscope to help facilitate fertilization. And so sometimes I've counseled those men. I pull them aside and say, hey, is there anything else that, you potentially can do? And then I'll sometimes say on second or third questioning, I do drink pretty heavily. I have, a bottle of wine every other night. Weekends I'm golfing or, going out with my buddies and drinking more heavily. And, we see some modest sperm issues and they stop. And after several months, we see a pretty good improvement in the sperm quality. And lo and behold, they get usable embryos and their partner gets pregnant. Right. So those lifestyle changes and adjustments can go a long way. Managing your diet such that you're eating healthfully and also trying to get to or maintain a healthy BMI range can really be helpful. Men who are obese, overweight, that extra adipose tissue is actually making peripheral estrone, and that actually might inhibit testosterone function and also sperm production. And so we have seen some men through, a combination of different factors, lifestyle, medical support, lose weight and also see improvements in their sperm as well as their underlying cardiovascular and metabolic health, right? So it's not just for reproduction. I mean, think about it. If you're going to be a parent or you want to be around for them for a long time, ostensibly.
I know you had mentioned birth control use before and how this may affect fertility. If we had been on birth control for an extended amount of time, say 11 years, and now have not conceived after 7 months, should we consider seeing REI sooner? Or can this be normal? And could we continue trying for a year or so?
So if you are under the age of 35 and you have pretty predictable cycles, like sometimes people are like, I don't have regular cycles. I'm like, tell me what you mean by, your cycles are irregular. They'll say, oh, I have intervals of like 26 to 30 days. And I'm like, and with no bleeding in between periods, I'm like, that's actually a pretty regular cycle. But if you have pretty regular cycles like that, and you're under the age of 35 and notice your menstrual patterns really haven't changed much, pretty consistent, pretty regular bleeding, 3, 4, 5, 6 days. No real known medical history, family history of early menopause or anything like that. Then I think it's not unreasonable. Again, depends on your approach to life. If you're someone who likes to be a problem solver, likes to anticipate things, then at the 7-month mark, I would not lose heart. I would keep on trying on your own. And by trying on your own, I mean, I saw a question about ovulation predictor kits. I don't think they're necessary if you have fairly regular cycles. I think if you just try to make sure you can, again, understanding that your schedule are busy, try to have intercourse 2 to 3 times per week. I think for most people, that's the most fun, enjoyable way to try to approach conception attempts, at least in the beginning. Because sometimes using ovulation predictor kits can be a little stressful for some people. But back to this question about being off OCPs and trying for 7 months. If you're one of these like doers, like to plan, then yeah, go ahead and start thinking about at least calling up, getting an appointment made with an REI at the 7 month mark. You'll probably get in to see them at the 8, 9 month mark, 10 month mark. If you're one of these people who's like, no, I don't like to rush things. You want to kind of see if this is organic. I think seeing a doctor now is going to be more stressful. Then wait a little longer, maybe at the 10, 11 month mark to go and making an appointment. If you're 35 or above, then I would consider, definitely at the 6 month mark, and now you're at the 7 month mark. At least think about, I wouldn't stress overly, but I would think about trying to set up an appointment with an REI.
Beyond general healthy lifestyle habits, what are other modifiable factors women should be thinking about when it comes to fertility? For example, are certain common psychiatric or blood pressure or other medications associated with fertility issues?
That's a great question. If we're talking about medications that are frequently prescribed for like depression and anxiety, SSRIs, those do not seem to affect fertility for women. And in fact, really important to stay on if you find that you're having symptoms that keep on recurring when you come off those medications, even while you're trying. And I would advise also, if your REI or GY can give you good advice about whether or not you should continue, try to find a reproductive psychiatrist. Most psychiatrists who've recently trained should be knowledgeable enough on the fact that SSRIs are okay to use for mental health needs, even for people who are pregnant trying to conceive. Some old school, old timer ones aren't as well versed. So that's why I wouldn't want you to sort of stop something that's really helping your mental health. What was the other medication? Oh, antihypertensives. Just keep in mind that there's certain antihypertensives that are contraindicated in pregnancy, like I believe ACE inhibitors. And so if you are on antihypertensive, it probably would be prudent as you're thinking about family planning, family building, to also consult with, if not your OB, maybe with an MFM, just to do a drug alignment for pregnancy health as well. Other kind of separate from that, making sure if you're on thyroid medication, that's well kind of dosed, because you want to make sure that you're euthyroid. Make sure that if you're on medications for epilepsy, there's some drugs that are probably better to use, safer to use if you're trying to conceive than others. Make sure that for anyone who's thinking about trying to conceive, you're on a prenatal vitamin folic acid. Numerous studies have shown that 400 to 800 microgram folic acid daily dosage used starting 1 to 3 months preconception in women really dramatically reduces the risk for neural tube defects like spina bifida. And then other lifestyle things to pay attention to. This might be like a duh, why are you telling us, Janet? We're doctors, but I can't tell you how many well-educated women, well-versed women about health even, don't realize that an IUD or a diaphragm is not really adequate barrier protection against STIs. And remember, chlamydia, gonorrhea are on the rise and can be insidious, almost virtually asymptomatic, and can lead to fallopian tube damage such that you might be suffering future infertility due to tubal occlusion. So even if you have an IUD, I would argue, quite honestly, I mean, my husband makes fun of me about this, but even if you have a trusted partner, I would really encourage you to think about barrier protection as well.
Thank you. I'll hand it back to Dr. Cork to close us out.
Thank you. Thank you, Dr. Choi. It was a very informative lecture. Still lots of questions in the chat, so this is a hot topic. I want to tell everybody who is part of CIR that the Reproductive Justice Task Force will continue to host informational series and a social media campaign on infertility, family building, as well as we support our abortion efforts. In the next few days, we will send you a copy of the slides for this presentation, as well as some links. And we hope to be able to interact with you through our WhatsApp group. We will also send you the information for that. So again, I want to thank everybody so much for joining, your participation. And thank you to Dr. Choi and Progeny and all of our CIR staff for making this possible. Have a great night, everyone. Bye.
Thank you all for your attention and these great questions. Have a wonderful evening.
Thank you.
Bye-bye.
Bye, everyone.